لا عادي.
الجميع؟ انتوا كنتوا بجرش اليوم وجيتوا من جرش؟
لا دكتور اليوم مفيش دوام كان مفيش
ما كان عندكم دوام. اوكي that's fine. طيب Peptic Ulcer disease. I mean, these are the cells which you find on the oxyntic glands in the stomach. You know, parietal cells secretes what? Hydrochloric acid and intrinsic factor. Okay. Chief cells, pepsinogen, G cells, gastrin, delta cells or D cells, somatostatin, although they're very common in the antrum. Okay. And ECL cells, they secrete histamine. Okay. And this is just to demonstrate to you what happens on your parietal cells, which receptors there are. There are muscarinic receptors for acetylcholine, and that's where the vagus nerve and stress and anxiety plays a role in increasing your acid output. There are H2 receptors, okay? And there are gastrin. Actually, it doesn't work on gastrin receptors on the parietal cells. It works through the CCK receptors. And remember, the main way, the main mechanism through which gastrin works is through the ECL cells by stimulating histamine release, rather than by directly on CCK receptors on the parietal cells. So this is probably the main way through which gastrin works, through the histamine receptors via ECL cells, okay? But this is the HK ATPase pump, which secretes acid out and takes potassium in. That's what we call acid or H plus K potassium ATPase pump. In exchange for potassium from the lumen, it secretes acid, hydrochloric acid. But what's an ulcer? We all know what's an ulcer. It's a mucosal breach that occurs in peptic ulcer disease in the stomach and the duodenum. It goes as far as the muscularis mucosa. Can you see this? Whereas erosions in Umul Khudush, they're superficial to the muscularis mucosa. This meeting will end up in 10 minutes, okay, Fahmanin, okay? The most common causes of peptic ulcer disease, combination of H. pylori and nonsteroidals. Nonsteroidals includes the classical nonsteroidals, the aspirin, and Plavix, diclofenac is also an ulcerating medicine, and don't forget steroids, okay? I told you here, steroids alone do not increase the risk of peptic ulcer disease. However, when they are taken in high doses, sometimes with combinations, the risk of peptic ulcer disease is greater. However, if you take steroids in high doses, you can cause peptic ulcer disease still, okay? Duodenal ulcer symptoms, this is what we always say. Duodenal ulcers are associated with hyperacidity, hyperchlorhydria. So you need high acid output to make duodenal ulcers, whereas gastric ulcers are usually not associated with hyperchlorhydria. They're actually associated with hypochlorhydria, okay? Gastric ulcers are usually worse after food, okay? And duodenal ulcers are worse on empty stomach. This is not always specific, and we don't usually ask about it in the symptoms. But people believe that duodenal ulcers are worse when you're fasting, and gastric ulcers are better when you are fasting. But that's not a very rigid rule. You need to know that duodenal ulcers are associated with hyperacidity, hyperchlorhydria, and gastric ulcers usually with hypochlorhydria. H. pylori, very common worldwide, gram-negative bacillus. It has a flagellae and a spiral. It lives in the mucus layer at the mucosa. It doesn't usually penetrate into the lining of the stomach, okay? It's very slow growing, and it doesn't need much of oxygen, and that's why it can survive. How does it live in the hyperacidic environment? It has several acid resistance mechanisms. Most importantly, it changes urea, hydrolyzes urea into into alkaline ammonia. What does that mean? It has a urease activity. Urease is the enzyme which hydrolyzes urea, changes it into ammonia. So urea to ammonia, urease activity. This bacteria has its activity, and that's why in the acidic environment, it creates a neutral environment surrounding it by neutralizing the acid by producing ammonia from urea. Okay? Now, how do we treat it? Triple therapy or quadruple therapy? And first, let's see how we test it. What tests do we know about H. pylori? There are tests that are based on endoscopy, and there are tests that are not based on endoscopy. I like to classify the test into antigens tests. Antigen test is the urea breath test, is an antigen test. The stool antigen test, okay? The biopsy on endoscopy is also an antigen test because it relies on the urease activity of the medium we put the biopsy in. Histology, you could argue, is also an antigen test because you see the bacteria on H&E staining. Culture, we take gastric biopsies, we send it for culture in patients that who have been very resistant to classical treatments for H. pylori. We send it for culture, and that is also an antigen test. The only non-antigen test we know is the serology. Serology, usually we do the IgG one, and it indicates exposure, and on its own, it doesn't mean that you have the bacteria, whereas the antigen tests mean you have the bacteria. This one, this one, this one, this one mean all of these, they mean you have the bacteria. Whereas serology, it does not necessarily mean that you still have the bacteria because a good percentage of patients who were successfully treated before may still harbor a positive serology after successful treatment. When the antigen is negative in all of these, still the IgG will be positive, and doesn't mean you still have the bug. It means that your IgG persisted after you have successfully treated the bacteria, okay? We cannot use it. It cannot be used for patients who have been successfully treated. If you treat someone for H. pylori and you want to check if you have been successfully treated, you cannot do a serology test. You need an antigen test, okay? When do we do a serology test? We do a serology test if we cannot do an antigen test. Antigens are affected by what? They're affected by PPIs and antibiotics. So anybody who's on PPI, how do we treat H. pylori? We give PPIs and we give antibiotics with it. If you are on a PPI, or you have been on a PPI until recently, or you are on antibiotics of any sort, or you have been on any antibiotics recently, you cannot do antigen tests because the count of the bacteria will be suppressed and the antigen may be falsely negative, the antigen test, okay? So this is where serology can come in, because serology is not affected by the antibiotics or PPIs. See here, not affected by recent antibiotics or PPI proton pump inhibitors, okay, compared to the antigen test. So we can rely on serology to diagnose H. pylori, but with one condition, that the patient has not been treated for H. pylori before. Because if he has been treated for H. pylori before, he could be positive serologically, but he doesn't have the bug. As I've already told you, many patients who've been treated for H. pylori before successfully will still have a positive serology, okay? So serology is, if you cannot do the antigen test for any reason, like PPIs or recent PPI use, or on antibiotics or recent antibiotic use, but with one condition, you cannot do it if you have been treated for H. pylori once or more before, okay? فهمانين؟ صعبة ولا سهلة؟
لا واضحة دكتور.
أعيد؟
لا تمام دكتور شايفه.
سهلة؟ أوكي. طيب.
الله.
H. pylori and non-steroidals, all of them cause peptic ulcer disease, mainly duodenal, okay? maybe half the world or even more have H. pylori. H. pylori can cause a specific type of gastric tumor called mucosa-associated lymphoid tissue lymphoma. It's a lymphoma. It's a maltoma, we call it, okay? Sometimes it can cause adenocarcinoma. So it's a carcinogen, potential carcinogen, okay? Maltomas are specific to H. pylori, whereas adenocarcinoma, they can come from other sources, but H. pylori is one of the causes. When do we acquire it? We don't know, but we believe it's over a long period of time, and it's not acquired acutely. It's been acquired since childhood, okay? It's much higher in our part of the world than in the West because of low socioeconomic statuses and household crowding, okay? What does H. pylori do in your stomach? If you're living in a developed country and you're Western, H. pylori mainly causes antral gastritis, okay? Affects your antrum. I've already told you that your antrum has these cells, D cells, and they secrete somatostatin. What does your somatostatin do? Somatostatin inhibits your acid secretion, okay? So when you have antral gastritis due to H. pylori, this one, your somatostatin is down. What does that mean? In response, how does somatostatin inhibit acid secretion? Did I show it in the slide? Let me show you.
يعطيك العافية دكتور، عذرا عن المقاطعة بس. دكتور بس باقي أقل من دقيقة لهذا السيشن، فراح يسكر تلقائي ونرجع نفوت على نفس الرابط.
بس يقطع. What does somatostatin do? It inhibits this role, okay? It inhibits the gastrin-induced acid hypersecretion. So it inhibits this part. So if you have antral gastritis due to H. pylori, your somatostatin is low, okay? What does that lead? Negative feedback is lost. Your gastrin will rise.
معك دكتور.
Can you stop the recording, please?
وقفت الريكورد دكتور.
Okay. طيب, let's come back to where we were. وين كنا احنا؟ This one. Okay. خليني أشوف. This is down. This is what I wanted. Thank you. Peptic ulcer disease. Okay, let's come back to our next, this slide. So we said somatostatin will be low because you're destroying the cells which make it in the antrum, the D cells. And in return, your gastrin will start rising because it has lost its negative feedback, and your gastrin will give hyperacidity. So this is what we call corpus sparing H. pylori gastritis, which means the body of the stomach, which is this bit, is not involved. It's only the antrum, and the body is very rich in parietal cells, okay? So corpus sporing antral gastritis is associated with hyperacidity, and that's the most common type we see in the Westerners, okay, with Western countries, and that's why the duodenal ulcers are much commoner with H. pylori in the West than in our part of the world, okay? Next slide is in our part of the world, or Southeast Asia, or Southern Europe, or Central and Eastern Africa and South America, okay? شو H. pylori, what does it do? It does pan-gastritis, كل stomach. So it's not sparing the corpus, it's affecting the corpus and the antrum and the fundus, and that the parietal cells are here, it will decrease your acid secretion. Okay? Now, this is associated with what? More of gastric ulcers and gastric adenocarcinoma. فهمانين يا حبايب ليش بصير عندك low acidity بصير عندهم this pan-gastritis is associated with hypochlorhydria. طيب complications, most commonly bleeding. This is managed by endoscopists, gastroenterologists like myself. This one is usually a surgical indication, perforation. Penetration is perforation backwards without, it's like a sealed perforation. It penetrates into the organs underneath, like the pancreas and so forth. Sometimes it doesn't need surgery. It's like a sealed perforation. Obstruction, extremely rare, especially that nowadays we are treating most of the causes of peptic ulcer disease, but you may have a gastric outlet obstruction if you have severe duodenal ulcerations in the duodenal bulb, in the bulbar duodenum. Okay, clear? Most common, this one. Okay, gastric erosions, can you see? It's like a scratch. Gastric ulcer, this is non-steroidal induced, pre-pyloric. This is erosions as well. An ulcer is to the muscularis propria. This one is only superficial, and this is an advanced gastric cancer. Management of H. pylori. You check an antigen test after you've treated H. pylori. How do we treat it? There are many regimens. Quadruple therapy. This is omeprazole, bismuth, tetracycline, metronidazole for 14 days. This is the classical quadruple therapy, and we used to reserve it for severe resistant cases. Nowadays, most H. pylori are resistant to clarithromycin, which is this C, clarithromycin, and many of them are developing resistance to many other antibiotics. So we are sometimes left with no choice but to start with this regimen, OBTM, which is the classical quadruple therapy: omeprazole, bismuth, tetracycline, metronidazole. Okay, hypergastroneemia, because we need to come to this. Now, there are two types of hypergastroneemia. If you are secreting excessive gastrin spontaneously due to a tumor, you will have hyperacidity. Yes? So if you have a spontaneously or a primary source of gastrin secretion that is not dependent on the normal physiological process I've just shown you, you will have hyperacidity. And your pH in the luminal, gastric luminal pH will be very low, hyperacidic, pH less than 2. Okay? And these are usually pathologicals. All right? Whereas the appropriate hypergastronemia most commonly caused by PPIs. Why? Because when you give PPI, what do? You work on the HK ATPase pump. صح ولا لا؟ صحيح؟
كنت عيد دكتور.
When you are taking PPIs, where do the PPI work?
On the parietal cell.
على ايش؟ على HK ATPase pump. صح؟
Yes, صح.
So if you're taking PPI, you're preventing that pump from secreting acid into the lumen. فما عندك acid. شو بصير بالgastrin? It will rise, trying to push more acid out because it has lost its negative feedback. زي الهايبوثايرودism اللي عندهم هاشيموتوز. They don't make T4. شو بصير بالTSH?
rise يعني.
بصير raised. Okay. نفس الشيء هون. لما تكون عندك PPI, you're suppressing the acid secretion, and your gastrin will rise significantly. This is appropriate. This is physiological. صح؟ الشيء الثاني واحد عنده pernicious anemia. شو بصير بالpernicious anemia? It affects your body. It kills your parietal cells. ما في acid بصير عندك appropriate hypergastronemia. The same thing. صح؟
Yes.
صح ولا لا؟
صح مظبوط دكتور.
واحد عنده H. pylori pangastritis. I've just shown you H. pylori pangastritis also kills your parietal cells. So you will have hypochlorhydria بقل الأسيد بصير عندك secondary اللي هو appropriate hypergastronemia. صح ولا لا؟
Yes.
Finally vagotomy لما تشيل ال ACH على ال ACH receptor muscarinic عفوا مش muscarinic على ال ACH receptor acetylcholine receptor على parietal cell. When you do vagotomy okay بقل الأسيد بصير عندك hypergastronemia. All of these will give you reactive physiological appropriate hypergastronemia. صح؟ بيكون ال pH inside the stomach is ما عندك acid بيكون raised more than 2. Zollinger-Ellison شو هذا Zollinger-Ellison؟ It's a primary gastrin. What does Zollinger-Ellison secrete? It's a tumor arises in the pancreas or in the duodenum and secretes gastrin on its own. صح? This is gastrin that is independent of acid, and this gastrin will continue working on your CCK cells and through histamine to produce more acid. So the pH will be very low. Okay? سهلة؟
دكتور
واضحة؟
إن شاء الله.
واحد عنده H. pylori antral gastritis, antral G cell hyperfunction اللي هم عنده antral predominant H. pylori infection بصير عندهم ايش هذول كمان؟ بصير عندهم inappropriate gastrin secretion. اوكي؟ لأن الاسيد تبعهم بيكون عالي. طيب احنا نركز على Zollinger-Ellison. So it's caused by gastrin release from neuroendocrine tumor, a gastronoma. Very low incidence, commoner in males between 45 and 50. Majority of gastrinomas are malignant. They're not benign tumors, and they may be multiple. Most commonly sporadic. They're not familial, not in the multiple endocrine neoplasia type 1 syndrome. Most of them are sporadic يعني متفرقات, not familial, not hereditary. In men, 1 is the familial one. It accounts for around 25% of the cases. كلاهما هذول the gastrinomas are not present in the pancreas. They're present more in the duodenum than in the pancreas. But the most 2 common sites are duodenum and pancreas. Sahel? طيب, what are the components of men 1? تذكروهم? 3 P's. Parathyroid gland, hyperplasia, تعطيك hypercalcemia. إذا جاك واحد عنده hypercalcemia and you suspect hyperparathyroidism due to hyperplasia, and he has peptic ulcer disease, think multiple endocrine neoplasia type 1, which is an autosomal dominant inheritance. Okay? So hypercalcemia due to parathyroid, hyperparathyroidism. P, parathyroid. Next one is pancreas. I told you it's not meant to say in men 1, I told you the sporadic Zollinger-Ellison, which is the most common, the site is duodenal. Whereas if you take men 1 alone, which is the rare type, the site is pancreatic and gives you gastrinomas. These are pancreatic gastrinomas, ماشي, most commonly. And they also have pituitary tumors, okay? So what else distinguishes Zollinger-Ellison from men 1 is what? The higher incidence of a rare gastric tumor called carcinoid, okay? Although بيجوا مع carcinoid syndromes, men 1, okay? Whereas patients with sporadic gastrinomas, they don't have carcinoid tumors, okay? بتعرفوا الكارسينويد syndrome, صح؟
Yes, دكتور.
carcinoid syndrome, تعرفوه؟ كلهم بصير عندهم 5-hydroxytryptamine serotonin release from carcinoid tumors, whether anywhere in the small or large bowel, and sometimes even in the stomach, foregut or hindgut. Okay. Clinical presentation. شو بتتوقع واحد عنده hypergastronemia and hyperacidity؟ شو بتتوقع يكون عنده؟ Peptic ulcer disease. بصير عندهم diarrhea, not necessarily bloody. ممكن they may not be bleeding peptic ulcer disease. They may not bleed. بس عندهم diarrhea as well. بس عندهم severe reflux. صح لأنه هذا معدته مليانة acid. Okay. And 10% will only have diarrhea only. The message here is it doesn't have to be bloody diarrhea with every peptic ulcer disease. Zollinger-Ellison syndrome, diarrhea is mainly non-bloody. And the peptic ulcer disease may not even be bleeding. Okay. The most common site of peptic ulcer disease is the usual duodenum. That it is extensive, multiple, and can be affecting other sites as well as the stomach. Okay. Diarrhea is the second most common clinical manifestation, 50%. It's usually sometimes even it can take place with peptic ulcer disease. Doesn't mean that peptic ulcer disease has to be bleeding all the time. Why does diarrhea take place? We don't know exactly, حقيقة, but we believe that due to high volume of acid secreted from the stomach into the small bowel, it leads to pancreatic enzyme inactivation. It burns the pancreatic enzymes and damages the intestinal epithelial surface by the acid. All of these are factors contributing to non-bloody diarrhea. Esophageal symptoms, self-explanatory. Reflux due to hyperacidity, volume, and very acidic stomach. How do we diagnose it? The most common way, we do a fasting gastrin level. If it's more than 10 times the upper limit of normal, and at endoscopy, because this could be due to PPI. صح ولا لا? So you do an endoscopy, you do a pH study on endoscopy, and it's very acidic. If it was PPI, it should be neutral here or almost alkaline. So that on its own is diagnostic. Sometimes you don't achieve this target, and you do secretin provocation test. Secretin in Zollinger-Ellison syndrome does the opposite of what it should do in normal circumstances. So serum gastrin is measured before and after you inject the secretin. The normal response to secretin would be a fall in serum gastrin. But in Zollinger-Ellison syndrome, there is a paradoxical increase of more than 200 picogram per ml in serum gastrin. So there is a paradoxical abnormal reaction to secretin. And sometimes we measure the basal acid output. I will not ask you about those, okay? I just want you to know that Zollinger-Ellison syndrome is very inappropriate, very acidic stomach, and very high gastrin and hydrochloric acid. How do we allocate the tumor? I told you in this sporadic, the most common is duodenal. The best and the most accurate way is an octreotide scan. Okay? An octreotide. It's a nuclear medicine. Okay? There are many other ways like CT and MRI, EUS and angiography, but octreotide scan is the most accurate. Treatment is PPIs. If you can find the tumor and resect it, do, but that's probably all what you have to do. Upper GI bleeding ما حكينا فيهم سابقا كثير هذول. I will concentrate on non-variceal upper GI bleeding because that's related to peptic ulcer disease. حكينا فيهم كثير. فاهمانين؟ What's upper GI bleeding? يجوا وريتكم هاي الصورة بالوجران كثير. It's bleeding above the ligament of Treitz. صح؟ نمتوا يا أولاد؟ يا
لا
بنات؟
لا واضحة دكتور، واضحة. لا واضحة دكتور.
Okay.
إن شاء الله.
Where is the ligament of Treitz? Duodenal junction. So it's bleeding from D4 and above, or it's bleeding above the jejunum. Okay. But what symptoms? Hematemesis indicates upper GI bleeding. Melena usually indicates upper GI bleeding. It takes more than 14 hours to develop, but around 10 to 15% it can be lower. If you have hematemesis and melena, it's upper. If you have melena alone, it is very likely upper, but it could be, in rare circumstances, it could be lower. Now, symptoms, hematophysia. What is hematophysia? Is when you pass large amounts of red maroon blood rectally, and usually associated with hemodynamic instability. The most common cause is colonic, sigmoid diverticulosis, not diverticulitis, diverticulosis. If you have a massive brisk upper GI bleeding, that means you're pouring large amounts of blood into this small bowel and into the colon, and with rapid intestinal transit, you may develop hematophysia. And so you can have hematophysia with massive or brisk upper GI bleeding, okay? And these patients are more likely to die than classical hematophysia from colonic reasons, because they have bled much higher volumes of their intravascular volume, and they will be at much higher risk of death from shock states and cardiac arrest due to significant intravascular depletion. Okay, so that's why if you suspect hematophysia due to upper GI bleeding, do gastroscopy first. Okay, I've already shown you that you can have hematophysia due to upper GI bleeding. That doesn't mean this is the most common. The most common cause of hematophysia is colonic. So from upper GI bleeding can have the most common peptic ulcer disease and then variceal upper GI bleeding, okay? And there are other causes which are rare. Now, someone with GI bleeding, you have to know the hemodynamics, the blood pressure, the heart rate, the hemoglobin. One thing, if you suspect variceal upper GI bleeding, try to avoid excessive blood transfusion. You don't want an HB above 8. Or keep an HB of around 8 is enough in variceal GI bleeding, whereas in non-variceal GI bleeding, you can transfuse as much as you like. But don't over-transfuse if you suspect variceal upper GI bleeding. If someone has been bleeding for a long time, you may see features of iron deficiency anemia, macrocytosis, hypochromia with raised RDW. One thing, urea is raised in upper GI bleeding, because urea, which is released from the blood, from the degradation of the amino acids coming from globin, which is the protein of hemoglobin, will be absorbed from the small bowel distal to the site of bleeding, distal to ligament of Treitz, and that can only take place in upper GI bleeding. It doesn't take place in lower GI bleeding, as lower GI bleeding, when I say lower, I mean colonic lower GI bleeding, which is the most common site. So that's why a raised urea helps you or guides you that I may be dealing with an upper GI bleeding rather than a lower GI bleeding. Okay, I've advised about this before. Try to avoid insertion of a nasogastric tube in someone who is coming in with features of upper GI bleeding. Our surgical colleagues may tell you otherwise. Okay, why is it useless? Because of this. A non-bloody nasogastric aspirate may be seen in 15% of patients with upper GI bleeding who present clinically with serious hematophysia. These are the most seriously sick patients, okay? And they're bleeding, they're hosing. 15% of them, the NG tube will not show blood. So what's the point, okay? The other thing is a bile-stained appearance on the NG tube definitely does not exclude upper GI bleeding, okay? Because there are reports of bile in the aspirate are incorrect in around 50% of cases. The nurse says, oh, this is bile, this is not blood. Or the surgeon says, oh, this is bile, not blood. He's mistaken in 50% of the cases. You see? So that my message is testing of aspirates that are not grossly bloody for occult blood this is the third point, sorry. The third point, Some surgeons may say, oh, I'm not sure, is this bloody or what? I'll do an occult blood test on the aspirate. Also useless. Okay? Useless. So what's the message I'm trying to convey to you today? Don't rely on insertion of a nasogastric tube and what you see via aspirating the nasogastric tube in making your judgment of what type of bleeding, upper GI bleeding you're dealing with, or in making your judgment saying, oh, this patient has upper GI bleeding or does not have upper GI bleeding. Okay? Trust the patient, trust your history skills, trust your examination, trust your vital signs, trust your raised BUN, but don't trust a nasogastric tube. Okay? واضح كلامي؟
Yes, doctor.
بجوز السيرجنز يعلموكم مختلف. Surgeons will not ask you about GI bleeding, they will ask you about lower GI bleeding. The one who will ask you about upper GI bleeding is me, and when I would never expect you to say we insert an NG tube. That is a terrible mistake. Why? For all those reasons. Here, here, and here. Okay. Rokal, how do we classify, what scoring systems do we have for GI bleeding, upper GI bleeding? We have Rokal score, age, shock, comorbidities, gives you a pre-endoscopy score. These are clinical, okay? Patient's age, heart rate, blood pressure, and his comorbidities. These scores will give you a value, and the higher the value, the higher the risk of rebleeding, okay? Okay. Endoscopic findings also matter. So if you have pylori tear, you score 0. That's not life-threatening, okay? Whereas if you have actively bleeding clot or ulcers, that's very serious. It will give you 2, okay? فاهمين علي حبايبي? Okay? And you can have a post-endoscopy score. You could add them together, and both of them will give you what you expect. Okay, so these are 2 scoring systems. Rokal, pre-endoscopy. I will not ask you for post-endoscopy. Always use the pre-endoscopy because you're in the ER. I am the one who scores it post-endoscopy, not you. The other one, which is more thorough, which is probably you need to know, is the Glasgow-Blatchford score. This one is the patient's hemoglobin, blood pressure, comorbidity, heart rate, and other problems, hepatic and cardiac failure, and don't forget BUN. Okay, so this is more of clinical, and this is probably more thorough to you as new doctors. Glasgow-Blatchford, and it gives you an idea, stratifies patient into risk of and mortality. Okay, now peptic ulcer disease are the most common causes of non-variceal upper GI bleeding, 50% of the cases. But there are other causes of non-variceal upper GI bleeding. Tumors, where are they? Malignancies, okay? Non-variceal upper GI bleeding for what is this? It says this is classifying upper GI bleeding into non-variceal and variceal, okay? But there are many other, these are all non-variceal. Yes, they should be with this one, but I put it separate for peptic ulcer disease. So non-variceal includes this and all of these. Variceal is separate, okay? So not all non-variceal upper GI bleeding are peptic ulcer disease. The very majority of them are peptic ulcer disease. That's why you've got someone with likely non-variceal upper GI bleeding, you have to ask about symptoms of malignancy, Mallory-Weiss, De La Foy, vascular erosion. They rarely bleed, but sometimes they do. But tumors, Mallory-Weiss, angiomas, angiectasias, De La Foy, many syndromes that can give you non-variceal, okay? Management, you all know it. Large bore peripheral cannulas or central line, give crystalloids, send blood for cross-match, CBC, liver function test, INR, and don't forget BUN, okay? Once the blood has been cross-matched, you can give it. If there is an urgency and blood is not available, you may give O negative. Non-variceal, you have to give IV PPIs. Why? Because I told you the very majority of non-variceal upper GI bleedings are caused by peptic ulcer disease. Last one, variceal GI bleeding. We'll talk about this when it comes to liver disease, but the message is don't over-transfuse. HB between 7 and 8 is good enough. And the second message is give two things, antibiotics, usually ceftriaxone, and second, terlipressin or octreotide. These are the two specific medicines. Here, you give PPI infusion for variceal, you give antibiotic, empirically على طول, and then terlipressin or octreotide, which I've written here. Okay? سهلة؟
يس دكتور إن شاء الله.
في شيء صعب؟
لا تمام دكتور.
أنا كنت مستعجل عشان ما أخركم لأن أنا عارفكم صايمين معظمكم.
لا دكتور إن شاء الله كويس.
يلا اسألوني، أنا قاعد بدي أسمع كل الأسئلة. يلا.
دكتور أنا عندي سؤال.
يلا واحد منكم اسألوا one at a time.
دكتور هلا في لو عندي lactating mother تمام عندها PUD symptomatic H pylori positive هلا شو الريجيمين الأفضل لإلها من تريبل أو كوادربل ثيرابي بحيث إنه ما نضر البيبي؟
ولا شوف there is no, the question is do you really have to treat it now when she's lactating؟ اسألي نفسك هذا السؤال. Does she have to be treated now? Probably not. صح؟ يعني and I always try to avoid giving any antibiotic for a lactating woman. Okay? But if she insists to continue lactating, you can give it. There's no safe regimen. Regimens are not compared with each other. None of those medicines is contraindicated in lactation. But what do I do in practice? I tell the mother, we will treat the H. pylori once you have weaned the baby. Especially if they're not. لأنه تعطيها هذول الميديكيشنز كلاريثرومايسين بيعمل severe nausea وبلوتينج بيعمل مشاكل كثيرة. فأنا دائما بقول no, I will treat H. pylori when you have finished your lactation. لكن if the patient has bleeding peptic ulcer disease أنا بقول لها شربي حليب صناعي وخذ التريتمنت. Okay? يعني you can, I wouldn't give these regimens in someone who's lactating, especially the strong regimens تبعون التتراسايكلين تبعون الفلاجيل تبعون البسمث. But if you really have to and the patient is insisting on lactating, you can. Like these drugs are not contraindicated in lactation.
تمام دكتور شكرا.
شكرا. شو مين بتتسأل سؤال ثاني؟
أنا دكتور بدي أسأل ليش دكتور حكينا إنه ما بيصير الهيموغلوبين ليفل يزيد عن 7 أو 8 بالفيرسيل بليدنج إذا بده يعطي باكد RBCs؟
Don't transfuse if the patient's HB is as down as 7.5 or 7 to 8. If it's below 7, you have to transfuse. لكن don't over transfuse. يعني واحد عنده هيموغلوبين 4 بجوز أعطيه وحدتين أو 3. مش مطلوب منك تعطيه 7 توصل الهيموغلوبين تبعه ل 11 أو 12. مطلوب منك ترفعيه between 7 and 8. Then if you over transfuse, you increase the pressure in the varices and they will bleed further. Okay? The message is variceal upper GI bleeding is different from non-variceal upper GI bleeding. Variceal, they can hose if you give too much blood. Non-variceal, it doesn't matter. فهماني? So don't over transfuse. Only transfuse if HB is less than 7, but don't overdo it. لا تروح تعطي 5 وحدات إلا إذا كان هيموغلوبين تبعه 2 مثلا. 2, I want to bring it to 7 to 8, I'll give probably 5. But if it's 5 or 6, I'll probably give 1 unit. غير عن non-variceal, I'll be more brave and more generous. Okay?
تمام.
سهل يلا مين كمان بده يسأل؟ هذا له أي أسئلة؟ أنا خلصت من عندي. السلايدات هذول كلهم معكم صح؟
دكتور موجودات.
يلا الله يوفقكم. شكرا جزيلا يا حبايب. Have a nice weekend.
جزاك الله خير.
سلام بالسلامة.